Hi everyone, Anna here with the Coding Guild. In this episode we are going to review the evaluation and management tables at the beginning of the CPT book and discuss how to use them in order to quickly and correctly answer coding questions. The tables in question are found on page 25 right before the EM section starts, but the pagination is in Roman numbers, so look for page XXV. The anatomy of the tables look like this for most EM services. On top, we have the EM service type. This is the first step in coding for evaluation and management services, where we determine what kind of service the patient is receiving. Is it an initial nursing facility care, like in this example, or is it a subsequent hospital care encounter, maybe an office or other outpatient visit or an emergency department service? Knowing the type of the EM service will direct us to the appropriate table at the beginning of the CPT codebook and the appropriate code range we can choose from. Once the visit type is known, we have to go on to determine the patient status. The patient status means whether the patient is new or established to the examining provider. In order to determine this, please see the EM guidelines and the decision tree on page 7. While status is always listed in the EM tables, it is not going to be relevant for every EM service type. For example, here in initial nursing facility care, the status is defined as new or established. So this table does not differentiate between new or established patients. Both new patients and established patients can be coded using the same codes and the same table. But elsewhere, for example, in home services, we have two separate tables, one for new patients and one for established patients. Make sure that you are looking out for this and you are in the right table before assigning any code, because if you notice, the codes are very different. Next, we have the required number of components specified. This tells us how many key components must meet or exceed the same EM level in order for us to assign that code. Depending on patient status for home services, it will be 3 out of 3 required components or 2 out of 3. Then we see the available codes for the selected EM type and patient status. The number of options will differ from table to table. For example, this one has 5 codes available, while the established patient only has 4 levels. Below the codes, we can find the required key components, the history, exam, and medical decision making. We have 3 key components in 2 sections, what might be a little bit confusing, so let's have a quick look as to what is going on here. The first section here is shared by the history and examination elements, and here is our clue. Number 1 and number 2 out of the 3 key components are to be coded from here. For example, if we have an expanded problem-focused history and a comprehensive exam, we will select these 2 rows within the same section on top of the required key components, one for the history and one for the exam. Here they are at different levels, but sometimes they can be the same. For example, here both the history and the exam are detailed, so our coloring overlaps. Half of it is purple and the other one is pink. And although we only selected 1 row in this instance, we have selected something for both the first and the second key components required from this subsection, so we are good. The second half of the key elements determines the medical decision making. No problem here, we are simply choosing the row necessary for the level assigned. After the key components, we can find the contributory factors: presenting problem, counseling, coordination of care, and typical face-to-face time. The first element from here, see there is number 1, is something that credentialing exams don't routinely use. It is more for real-life coding. In real life, it is not only the amount of documentation that will decide the final level of the EM service, but we also have to look at how serious the condition is that the patient is presenting for. We do this because with electronic health records, it is very easy to document a high-level visit, for example, a comprehensive exam and history, thus meeting the required components 2 out of 3, and the assign the highest code possible, 99350. But what if all that documentation was for a cat scratch or something minor like that? In that case, the highest level code assignment is not justified, so we have to look at the contributory factors, the presenting problem, and see that the self-limited or minor problem will drag it down to level 1. Again, this is real-life coding. For the exam, you can mostly forget about the presenting problem. They are not going to ask you to assign anything using this. Now, as for the second half of the contributory factors, that's a different story. Items number 2, 3, and 4 fall under the same category in a sense. They all belong to time. Evaluation and management guidelines allow us to code EM services based on time in some selected scenarios. 1. If the EM service type is office or other outpatient visit services or critical care, or we can use time for most other EM services if counseling and coordination of care dominates the service. Dominating means that at least 50% of the time spent with patient care was counseling and/or coordination of care, and it is so stated by the provider in the note. All tables have this, except for the emergency department services, because patient care is very hectic there. It would be very hard to establish average times. Great! Now that we have the anatomy of these tables down, let's see leveling. In our first example, we have a patient who is new to the provider and they are seen at home. An expanded problem-focused history and a detailed exam are performed with low medical decision making. This is a home service for a new patient, and the required elements will be 3 out of 3. Our code chosen must meet or exceed the same level for all the 3 key components as listed here. The history was expanded problem focused. The highest level code this can get us is 99342 because that's where the X is. The exam is detailed. This will get us to 1 level higher to 99343, again because the X marks the spot, and the MDM was low, having its maximum reach at code 99342. Let's see which code has all the 3 elements meeting or exceeding the same EM level. Code 99345 has none of the elements reach it, so it is definitely not a level 5 visit for this patient. Code 99344 has the same problem, no elements reach it at all. Now this one, 99343, has at least 1 element reach it, the detailed exam, but unfortunately that's not enough because look here, the required components are 3 out of 3, so all the 3 must meet or exceed the same level. Unfortunately, this code must be X'd out as well. 99342 looks much better. The history element reaches it, the exam element exceeds it, and the MDM again reaches it. Meaning that 99342 met the requirement, and this is our final answer to the question. Let's see another example. Established patient is seen in the nursing facility, history is problem-focused, exam is comprehensive, and MDM is moderate. Again, we have the reach of every component drawn onto the table. Now let's see which code will meet the required 2 out of 3 components at the same level. Code 993110 has 1 element reaching it, the exam, but unfortunately it stands alone and we need at least 2 elements, so this code cannot be chosen. 99309 will meet the requirement though, because it has the exam exceeding it and the medical decision making reaching it. So the answer here is 99309. Now let's bring in time. In this example, the established patient is seen in a rest home. The history is expanded problem focused, the exam is expanded problem focused as well, and the MDM is straightforward. In addition, we also know that the time was 44 minutes and more than 50% of it was spent on counseling and/or coordination of care. What will result in higher payment in this case? Using time to level the service or using the key components? Yes, the answer is time. Using time, we can get to code 99336, while the key components would only get us to 99335. And last, and watch out here, we have a new patient who is seen for an inpatient consultation. The history is detailed, the exam is comprehensive, and the medical decision making is high. We also know that the time spent was 99 minutes. Please pause the video and give it a go. Ready? Alright. The correct code is 99253, level 3. The type is inpatient consultation, and these codes can be used for both new or established patients, no difference. The required components is 3 out of 3, so all key components must meet or exceed the same level. That only happens at code 99253 because the detailed history reaches it, the exam exceeds it, and so does MDM. The reason why we are not coding by time is that the necessary statement about more than 50% of the time having been spent on counseling or coordination of care is missing here. Remember, only office or other outpatient services and critical care can be coded using a simple time statement like this one. All other EM visits must state that at least 50% of the time spent was spent on counseling and coordination of care. And this is where we end this topic today. I hope it was helpful. Don't forget to visit our website for more coding help and free coding quizzes. Thank you for being here with me today. I will see you soon in our next video.